So what do you do? How do you prevent? How do you treat these things? This is a total contact cast being put on someone. This is a very classic time-honored treatment that I still do today if it's indicated. I know how to put on a total contact cast. My team does too. What this type of cast does is completely distributes all forces in the foot equally and protects soft tissue at the same time. So it's a way to sort of modify contact pressures if you have an area of ulceration, okay? Again, we manage the neuropathy. We treat the neuropathy if we can, or we surgically treat the neuropathy. Peripheral vascular disease, we look for it, identify it, treat it, okay? Infection, obviously, we look for this. We prevent it if possible. We try to identify the right antibiotic and use that. We treat it. And again, I think molecular diagnostics are best. And then contact pressures. This is where surgery comes in for diabetic foot ulcers. Anytime you have a deformed foot, tight tendon, an area of elevated contact pressures that are leading to this ulcer in the setting of neuropathy and ischemia, if you can reduce the pressure on that wound, it will have a much better chance of healing more quickly. So I see a lot of patients that have been in wound care clinics for years, unfortunately, and they have a clear deformity, and the wound at that deformity is just continually debrided week after week after week after week. Very expensive wound care products are put on it again and again and again. It heals up. They come out of the contact cast after they've had their debridements for a while, and guess what? The ulcer comes back. Remember I told you 80% recur? When I see these patients, I try to identify what is causing that abnormal contact pressure, and I will surgically fix it. And sometimes that is what is required. As you know, if you followed me at all, you know I try to avoid surgery at all costs, but in these cases, sometimes surgery is the most conservative treatment plan. And so that's what I do.